Okay, hello everybody. Let me welcome you to our sixth session of our webinar series, Fetal Cardiac Imaging Using MRI. Just a short note at the beginning that this webinar will be recorded, as also the last webinars have been recorded. And yes, I'm Heide Böth. I'm the Clinical Affairs and the Customer Relations Manager at North Medical. And yeah, I'm happy to moderate you through this session today. Just a very quick overview of the status of fetal CMR around the world. You can see here on the map the green marks, and each mark refers to a site doing fetal CMR by using Doppler ultrasound gating. And in total, as information, we have now 47 devices in the market, and there are 15 devices included that are in the United States. And yeah, as you know, this is our sixth session today, and we have Julian Lütgens with us to present a complete clinical case from planning to diagnostic. And yeah, let me just quickly remind you that also the last 5 sessions on fetal CMR have been recorded, and you can find the link on our website. And the aim and the motivation of this webinar was for us to build a community networking and exchange. And yes, it's sad as this one is the last session of our webinar series. However, we have good news. We are within the planning phase in order to also plan a next series. And therefore, I'd like to mention, if you have any ideas or if you are motivated in participating, then please feel free to contact us. And yeah, we are happy about your ideas. And before I hand over now to Julian, I'd like to tell you that each of you, like each participant here in the meeting, can talk and also discuss with our expert. You only need to raise your finger and show us that you want to speak, and then I can enable you to do so. You have also the chance, if you do not want to speak, to paste your questions directly into the chat, and that will also work. And now, yeah, let me introduce you to Julian. We are very happy to have you here today. Julian, he's a radiologist at the University Hospital Bonn, and he's a director of the MRI in Bonn, as well as the director of the Quantitative Imaging Lab. And yes, so I will hand over now to you, Julian, and wish you a good session.
Yeah, thank you for this nice introduction, Heide. I will share with you a recording of a clinical scan we did actually yesterday. So I recorded this scan yesterday, and it's a video, and I will guide you through this video and make comments how to plan the sequences, what kind of sequences we use, a little bit pitfalls, and etc. So just for your information, so this is a scan of a fetus with a gestational age of 36 weeks, and we were asked to do the scan because the fetus we scanned, so it's a cardiac MRI scan, he has a huge mass in the back or in the neck, and this is thought to be an hemangioma. And what I found during ultrasound is a dilated pulmonary artery and a dilated ductus, and they asked whether there is any isthmus stenosis or aortic coagulation, or whether it's a steel phenomenon due to the large hemangioma. So we can jump right into the scan. I will start the video now, and the patient is now in the scanner room, and the device is not placed yet, and we first perform a survey to localize the fetus and also the fetal heart position. So we do a scan first before we place a transducer. And what you can see over here is that this is the survey of the patient. Over here there's the hemangioma in the neck. You can already see it, and that's just a very fast, balanced planning survey. And the next sequence I plan here right now is just a transversal T2-weighted single-shot sequence. And I also adjust the volume shim to the fetal heart. And after the survey, I now start with a transversal T2-weighted single shot images. And we do this just to localize the exact position of the fetal heart actually in relation to the belly button. And when we now this sequence starts, the second survey, and you can see the fetal position, head is down in the pelvis. And this is a 3T Elision X system, so we do a 3T Tesla scan, and it does shimming right now. Over here, we can see this is from our
Wait a
vital
second.
eye.
Julian,
Yeah.
can you just interrupt for a second, because there was in the chat function just a comment that there's someone who cannot see the presentation. So I can see everything wonderful and I can hear you wonderful. Does anybody else also have the same problem? Okay, the others can see it all fine. So Tokyo, it should probably be something with your connection. We would then just continue, Julian. I'm sorry for that.
So here's this is the respiratory curve of the mother. We have a camera in the magnet, which looks at the breathing movement. So it's a vital eye. And now after this shimming procedure, we now have the next sequence going on. This is just a transversal single shot T2. You can see the images which are quite live in the right corner over here. Maybe you just only see my head, but so here are the T2 weighted images, and now we can see the exact position of the fetal heart. And we also see the belly button of the mother. And this sequence we use to actually plan the transducer placement. So here with this sequence, with this transversal T2 weighted sequence, we decide where to place the transducer. And we have two options to plan it actually. Either to place this at the anterior wall, so the mother, she lays in left lateral position, and either we place it on the anterior wall or on the posterior wall, that we have a direct view of the transducer to the fetal heart. And in this case, you can see it over here that we use the anterior position, because there we have the beam of the transducer can directly point to the fetal heart. And if we use, for example, this position, there would be many uterine vessels which could lead to problems with deriving the signal. So what happens right now, you can't see it, but right now I'm in the scanner room and I made this planning. The belly button was over here, 10 centimeters to the left of the mother. I placed the transducer right now, and I can just show you the technique right here. So we just made this survey and then this axial T2 weighted single shot sequence, and now we do the transducer placement in this patient, and then we do another survey. So this is what happens right now in the scanner room. And maybe I forward a little bit that it took me like 2 minutes or so to get the transducer positioned in the scanner room. And what I do right now is to do a calibration of the trigger signal. So there are different channels which can use for the trigger, and we use network E. You can see it over here. And we have to wait a little bit, then you can also see the trigger signal appearing. We go forward. So there's the trigger signal. You can see it over here, and we do the calibration with the transducer signal. And once the calibration is done, then you can also see the heart rate over here in the left corner of the fetus, which is 144 right now, and we have a strong trigger signal. So this looks very nice. And what we do right now, so we now get the patient in again into the MRI scanner, and then we do a second survey, and then we do the second transversal T2 weighted single shot sequences. We don't do these transversal orientation, but we do then an orientation already to the fetal heart. So scanner door is now closed, and we start with the second survey. Over here you can see this large hemangioma at the back or at the neck of the fetus, and we can also already see a quite large heart. So there's a reference scan going on right now, and then the next survey will start. Just waiting. And now you see the lower curve over here, it's the respiratory signal of the mother, and this is the transducer signal of the fetus. So there is the survey once again. And like in the first survey, we adjust the volume shim to the fetal heart or the fetal thorax. And now we don't do a transversal T2 weighted single shot sequence, but we do a single shot sequence which is already orientated in this coronal view to the, which is transversal orientated to the fetal thorax. So it's slightly different. Also look that the fetal heart is centered in the field of view. Now again, there are some shimming going on. You can't see it. But if you're in the MRI scanner, you just hear it. And then we are forward a little bit. We should shortly see the second survey. Yeah, if you do a scanning on the 3T, so the shimming takes a little bit more time than if you do it like on a 1.5 Tesla system. That might be an advantage of the 1.5 Tesla system to do their fetal cardiac MRI scans over there, because you don't lose so much time for shimming purposes. But now we get our second planning sequence, the T2 weighted single shot with the transducer on. Over here you can see the transducer, and due to our planning it is nicely located to the fetal heart. So the beam of the transducer is directly located to the fetal heart. We also have the strong trigger signal. So what I do next, so this is a transversal orientated view of the fetal thorax, and we do our, if you like to call it, our third planning view. So it's a sagittal T2 weighted single shot sequence through the thorax, and we plan it in the volume of this transversal orientated stack. And it starts right now. And what you can already see here is that the jugular veins, they are very prominent and large, and this is the large hemangioma over there. And you could already see a huge feeder vessel. And this is the ductus arteriosus over there. This is the descending aorta already. So now we get our third planning scan going on. It's the sagittal view of the fetus. And we now use our oriented transversal view and the sagittal view to actually plan our transversal sinus stack through the fetal heart. And on our 3T system, we use an adaptive shimming, so we also have to plan our adaptive shimming stack over here, but it has the same field of view like our Cine stack. And what you can see, I do the orientation on this sagittal view and also adapt the field of view on this transversal view. And what I want to achieve is that the fold over direction or the read direction of the MRI is as small as possible. And I also always try to center the fetal heart within the imaging stack. So now the P1 calibration scan does take place, and this is the stack of our transversal Cine stack. You can see this is I increase the fold over direction, decrease the fold over direction a little bit to just fit the stack, the redirection to the anatomy of the mother and to make it as small as possible. Here's this large hemangioma, fetal heart, ductus. This again is the Cine stack, so it's now orientated transversal through the fetal heart, and the fold over direction or the phase encoding direction is as small as possible. And because we thought that we would like to visualize some feeder vessels, we enlarged the imaging stack to the head of the fetus, make it a little bit more slices. And now what I'm now doing is, so now we're getting our first triggered images here. And again, this is the breathing signal of the mother, and this is the transducer signal of the fetal heart. And we do manual breath holding with the mother. So we always look how is the trigger signal right now, and then we give the breathing instructions to the mother manually. And this has an advantage if the fetus, if you have some movement, for example, of the fetus, and you maybe have a loss of the trigger signal, you can wait and then give the next breathing command when you have a stable breathing signal again. And you can see me here giving this breathing instructions. And now the scanner, these dashed lines, they indicate that the scanner is acquiring the sinus section or the sinus slice, and the mother holds her breath during the slice. And then you can see the cine images over there. We can't see any movement yet because we are already, we're not already in the thorax, but we are in the more located to the head. This is this large hemangioma over here. It's a spine, cervical spine. And once again, so we now say the mother, breathe in, breathe out, and then we manually start the acquisition of the cine section. And I tend to start it a little bit earlier than the auto voice system of the scanner would do it, because it of course takes some time until everything, till the pulses are there, and you can save some milliseconds of it here. So if you start the scan a little bit earlier. So now we have a stack here. We're still at the cervical level, and there are some dilated jugular veins over there. Here is the hemangioma. Now we're slowly moving forward towards the aortic arch and the ductus arteriosus. And yeah, right now it's a very pleasant and calm scan, so everything worked very fine. We have a strong trigger signal. The mother is a good breath holder, so that's no problem. And we have slightly, so it's not a perfect scan. You can see this. There are some kind of blurring at the, so this is the ductus over there, the ductus arteriosus, the cranial aspect of the ductus arteriosus. It's slightly blurring and blurry. This is because they are, slight fetal movements. You can't influence this, and this might also be like breathing movements of the fetus. So it's not, the fetus is not perfectly calm, but what we see over here is, here's the aortic arch. Here's the ductus, which is quite prominent. This is what they saw in on the echo, and but we don't see an aortic coarctation at this level yet, because this was the question. This was our question to the scan: is there a aortic coarcation, or is it just is the ductus and the right ventricle just that big because of a steal phenomenon due to the large hemangioma over here? And what you can see over here, so there aren't any breathing artifacts actually from the mother. And so the mother is holding her breath quite perfectly, and this slight blurring is because of these slight fetal movements. So there's some flow, increased flow velocity in the ductus. And this over here, there is the aortic arch, and there's a connection between the aortic arch and then this in the aortic isthmus, but there isn't an aortic coarcation, so there's no stenosis in the aortic arch. It has the same diameter all the way, so we could already answer the clinical question actually with this transversal stack, and yeah, together with the dilated jugular veins, our anticipated diagnosis was that this is a dilatation due to the steal effect of the large hemangioma. We further moving downwards. This is the left ventricular outflow tract over there. I think it's always a little bit difficult to look at the images because they are not turned the right way. So if you look at the images of the PEC systems, we always turn it like we would also we would look like on a postnatal scan. And yeah, but what you can see is that the ductus is quite large, the right ventricle is quite large, and the scan is going on. And yeah, we acquired 17 slices on the CNS stack, and this also means that the mother has to hold her breath 17 times. So if you have a mother which is not a good breath holder, you can try it at the beginning. You can see how good she holds her breath, and if you see, okay, there are movement artifacts or she can't follow the commands, then you can also switch to a different mode that you do it, for example, free breathing. If you do increase your number of signal averages of your scan. So in this scan, we use the number of signal averages of 1, but you can also do it like move it on or increase it like on 2 and then do it free breathing. And what we can see very nicely on this scan, so right ventricle, left ventricle, but what we can see nicely is that the transducer itself, it's very nicely positioned onto the fetal heart. So what we do right now is we plan our next sequence. This is our 4D flow sequence. And yeah, we plan it sagittal. And we try to cover within our 4D flow, we try to cover the big vessels of the thorax, the ductus, and the aorta. So our sinus stack is nearly finished. Left ventricle, right ventricle, an open foramen ovale. The next sequence would start right now. It's a sinus sequence with a lower resolution. Of course, we want to look if we acquire a lower resolution, if we could increase the spatial resolution with deep learning, for example. So this is going on right now, but we are planning our 4D flow, and we look at the sinus stack that all our vessels of interest are included in the imaging stack. And once again, I try to adjust this 4D flow to that the fold over suppression and in the read direction, it's at the shortest diameter possible. And now what I'm doing here right now, I'm looking for the navigator for the 4D flow sequence. So we use a navigator, make it free breathing, and you can see over here that I place the navigator at the abdomen of the mother, and also take care not to place it on the transducer itself. So I'm still adjusting the 4D flow sequence over here. And you can see our acquisition time now is 3 minutes and 16 seconds, which is slight long. And also increase the number of slices over here. And now I try to reduce this acquisition time to get it a little bit lower. I play a little bit with the fold over suppression. So with the field of view, if you look if the TFE factor over there maybe jumps to 2, which would shorten the acquisition time by half. But as you can see over here, this doesn't happen. And now I adjust the acquired heart phases here. So it's a default by 70%. I adjust it to 65%. And what happens right now is due to this reduction, the TFE factor jumps to 2. And we have a reduction in our scan time by the factor 2. And now I take it. So in 1 minute 35, we try to acquire a 4D flow sequence here. You can see the low resolution sequence. It's not that sharp, but it's already not finally reconstructed. But we definitely have some fetal movements. But the advantage is quite obvious. So with this low resolution sequence, we can do so we do 2 slices in 1 breath hold. And yeah, it's a little bit faster than do it like the conventional way where you use like normal parallel imaging. What I do right now, I also plan a sagittal sinus stack over the aortic arch, because this was the question. And we also try to adjust our sinus stacks towards the clinical question. So I plan the sagittal sinus stack over there. Still quite heavy stack with 16 slices. In the region of interest, we don't need that many slices. So here's the aortic arch and the pulmonary artery. And I will adjust this, reduce the sinus slices to 7. And here you can also see over here, so we use a slice thickness of 4 millimeters with no gap. And yeah, you have to look what's the best for you. So you can also increase maybe your slice thickness to 6 or 7 and have a negative gap. You have to look at your images and figure out what works the best for you. And I planned the sagittal sinus stack here, but it's not already perfectly angulated towards the aortic arch. I will do a little adjustments later on. So we already finished our low resolution scene stack. Okay. What you can see over here is that now we have a loss of a trigger signal, maybe due to fetal movement. And the scanner is scanning all the time. There are some but trigger points left, and the sequence, it doesn't abort. This is good. And we didn't repeat it because it was the last slice. And now the 4D flow sequence starts. So this is a navigator display. Once again, we plant the navigator on the abdomen of the mother. Now I adjust a little bit the scene stack over the aortic arch, that we can better see how the ductus goes into the aorta. Now you can see the navigator over here and also the navigator window, and gating efficiency is good because there isn't that much movement actually at the abdominal wall. So the sequence or gating efficiency, it's around 80%. So sequence, it's very fast. And yeah, we have to pray actually that the fetus doesn't move within this acquisition, because if the fetus moves, you have to repeat your 4D flow until you get a good image quality. And this is, yeah, repetition of sequences. This is the key to success actually to a good fetal cardiac MRI exam, because if you have a movement of the fetus and for example, loss of a trigger signal or the slices are incoherent, then you have to repeat it. And from my experience is that you have to stay calm all the time. And if you think so the investigation was worth nothing, then the best imaging stack of your fetal cardiac imaging career will appear. So be calm. That's my main advice. So 4D flow is going on. Gating efficiency is still good. What I do next is I plan a T1 mapping of the fetal lung. We do it on this transfer view look where we have the largest diameter of the lung, and there we plan the T1 mapping and also the T2 mapping. Not quite sure how we use this data, but we acquire it on every scan. So 4D flow finished. Was quite good. We had a stable signal all the time. I now adjust the heart rate because the Philips scanner doesn't allow a higher heart rate than 100 for T1 mapping. But I think it's okay to reduce the trigger points because we don't want to look at the heart, just at the lung. And if you have heart rate of 100, so trigger point should be okay for T1 estimation of the heart, of the lung. What I do here is, okay, this is the T2 mapping sequence, it's the next sequence. And now the scanner is doing some preparation for T1 stack, and which is now there's the first reconstruction, first flow reconstruction of the 4D flow we just acquired, and we like to do like a MIP of this PCA reconstruction to look if the quality of the 4D flow scan is actually good or bad. I delete some sequences we don't need. So this is the MIP of the combined flow of the 4D flow. This is the vessel from the mother. You can see here there is some signal of the heart, and this is the ductus. but we don't see actually the aortic arch or the descending aorta in these images. So that's not a perfect quality for 4D flow. This is the T1 map of the lung. It's really nice. And because I didn't saw the, or we didn't saw the strong flow signal of the descending aorta and of the aortic arch, we decided to repeat the 4D flow sequence because it's always a matter of movement, heart rate, of course, and you have to wait for your lucky shot. And that's what we do now. So we repeat the sequence, just 1.5 minutes, multiplied with 80% efficiency. So it's a little bit longer than the 1 minute and 40, 20% longer due to your gating efficiency. So T2 mapping is acquired. Now we repeat the 44 scan. You can always look at the heart rate. So if the fetus is does many movements, you maybe have some variances in your heart rate. So it goes up. But in this case right now, so the heart rate is stable all the time at around 140, 150 beats per minute. So that's a good sign. And also the breathing, the mother, it's very regular, quiet. You can see it over here, navigator. It's a nice navigator fit over here, and scanner gating efficiency is good. So next sequence is after the 4D flow, which is now planned, our sagittal scene view through the aortic arch. And right now I plan an additional transversal or axial view due to the cervical vessels, to look for feeder vessels. This was our plan. Because the clinical answer is already answered, so there is no significant coarctation of the aorta. Now we have some problems with the gating signal, but it comes back. It's now stable again. And the 44 sequence is going on. So I increase the numbers of slices for this additional stack to the cervical vessels to 25. And because the mother is breathing so shallow and calm, we decided not to do any breath holding anymore because it might be exhausting for the mother. We here decided to do it like with a free breathing approach. So 4D flow, second 4D flow done. And it's getting reconstructed already. Our MIPed flow images. So we're now getting our first sagittal images. You can actually nicely see. Must be the ductus here. But what we can also see, so there is still some slight movement of the fetus. So it's a little bit blurry in the thorax. But there you can see the ductus going into the aorta. Right ventricular outflow tract over there. So we are diagnostic, fully diagnostic scan. but we have some slight fetal movement. So this is our second 40 flow, and you can see now that we have a little bit better signal. We can see now in this reconstruction that there is also some flow signal in the descending aorta. And yeah, this should be fine at this moment, because we had these slight movements all the time. I decided not to repeat the 40 flow once again. This again the mass. What you also already see, so that our loss of our transducer signal is getting worse. And you can see now I'm waiting until it's stable again, and then give the next breath holding command. Breathe in, breathe out, hold your breath, and then do the scan again. So if you do it manually, the breath holding commands, you can always wait until you have a stable signal again. And now we see that we got an unstable again, but then I just tell the mother she can breathe normally. And yeah, so the fetus is getting awake right now. It was a little bit better in the beginning. And now we wait again until we have a stable trigger signal, and then give the next breath holding command and do the next stack. So we're at the end of the exam actually. We answered the clinical question. We have an okayish, maybe okayish. I haven't seen the final reconstructions yet, but maybe an okayish 40 flow. And yeah, clinical question is answered, and what comes now, it's just to get better images and maybe a little bit more information, but clinical information we had to obtain in the scan, it's already there. Now you can see we already have this breath holding tab here over here, but the scanner is scanning right now due to the dashed lines. So we do it with 2 signal averages, but don't give the breathing command. So we just press continue scan without doing a breathing command, and we do slice by slice. You can also see that the SNR of the mother, of course, increases due to the 2 signal averages. And you can also see that the breathing movements are very subtle, but we have slight fetal movement over here. So this is why the fetus looks blurry. It's because the fetus is moving a little bit, but if it wasn't moving, you would have a perfect image quality despite free breathing of the mother. You can see that there isn't many breathing artifacts present, but you have to try it during your scan. Just told you, if you have a good breath holder, do breath hold scan. If you have a mother which does shallow breathing, and everything is fine, you can also do it free breathing. Maybe image quality, if you have a free breathing mother and very little breathing artifacts, image quality might be a little bit better with free breathing due to the higher SNR, but you have to look. So we now do this scan. You might ask, I can switch also to a recent presentation of our group. It was just published in Radiology Cardiothoracic Imaging, where we looked for fetal cardiac CNA MRI with Doppler gating in complex congenital heart disease. And we compared the diagnostic performance of fetal cardiac CNA MRI with Doppler gating against the reference standard, which was fetal echocardiography. And conclusion was that diagnostic performance was comparable for diagnosing complex fetal congenital heart disease. So if you're interested in this paper, you can download it, of course, on the website. And there you can also find some more information, for example, about scan parameters we use. So these are the same scan parameters we also use in this recorded scan. And yeah, if you want to rebuild your sequence. So we jump back again to our scan. Yeah, we just do some sinus scanning of the cervical vessels. Nothing special is happening here. Are there any questions so far in the chat, Heide?
No, so far there are no questions, but I have one, Julian. So we saw now several times that the signal was gone. When is the time when you decide to really go in and do a repositioning of the gating device?
Yeah, when we have really strong fetal movements, and we also see in the images that the fetus has moved significantly. So then I would repeat the planning sequences and look where it is located, the heart right now, and then we do a repositioning. But in this case, so we have these movements of the fetus, but it doesn't change the position, and you can see on the images, okay, this transducer lies perfectly actually. So in this case, I wouldn't readjust it, but if you start and you have strong fetal movements and you have problems with your trigger right at the beginning, I would always say, okay, let's go in and try to find another more stable position, and then do the scan. And yeah, patience is the best you can do. So be patient. Do your scans in the morning, for example. That's also more our observation that the fetus is a little bit more calm in the morning, and they get used to it. And if they fall asleep, you get the best images ever. I can guarantee. So just be patient. Don't give up too early.
Yeah, and maybe I missed it. The gestational week was
36 weeks.
36. Okay. Good.
So although we have slight blurring over here, we are fully diagnostic. We can see the supra-aortic vessels, we can see the veins, we can see the ductus. So it doesn't mean if you don't have a perfect scan that you can't draw any conclusion or make a diagnosis. So that's not the case. Yeah. Just be patient, wait, and you get awarded.
Great. Perfect. Are there any other questions in the audience?
We'll stop the video. It's all right now, so there's not much happening anymore. We just do a little bit more free breathing CNET images, and then we stop the scan, and you can see from our recording, so 50 minutes was the total scan time at the end, which is good, I would say. And also, yeah, take your time. Can also last maybe 1.5 hours if you want to do some good images. Maybe you are, if the fetus is asleep, maybe it only lasts 30 minutes. So, but you have to have an appropriate scan slot available, all circumstances. So don't plan your fetal cardiac MRI exams with a too short time slot, and then the next patient is waiting, everybody is nervous behind you. Take your time.
I think that is a very good recommendation. All right, so if there are no questions, I think we are almost at the end. So you have a chance now to raise your hand and also to talk to Julian, as I said at the beginning, so I can enable you to speak if you have another question. Otherwise, I would like just to mention one more thing. So yeah, of course, as I already said, we will continue with this webinar series, and I thank you, Julian Lütkens, very much for this very, very nice insight into the online clinical case. I think that was very, very interesting for our audience for the last session as well. And we will keep you informed on how we continue with this webinar series, and would like to thank you for your support and your attendance during the last 6 sessions now. And we believe that was yeah, very successful, helpful, hopefully, and probably we could yeah, reach our aim in order to create a community for fetal CMR. And in order to improve the next webinar series, I would really highly appreciate your participation in a feedback survey. It's really only 2 minutes maximum. And my colleague has now just put the link for the survey in the chat function, and I would really yeah, highly appreciate your attendance to this survey, and so we can improve the next webinar series. So contact me also anytime if you have any other feedback. I'm happy to chat with you, and yeah, thanks for your attendance. Thank you, Julian, again. Is there anything, Julian, you would like to say at the end, or?
If you have some questions, you can also write me an email. Yeah, thank you.
All right. Thank you all.
Bye-bye.
Bye-bye.